Good morning all. My name is Dr. Kritika and today my topic will be a fluids and basically we'll deal with the crystalloids. And our objective of the class will be introduction, characteristic features of crystalloids, classification of crystalloids, isotonic saline and dextrose and their indication, contraindication of the crystalloids. And first we should know about our concepts based on tonicity, osmolality and osmolarity. What is tonicity? It is a relative concentration of the solutes dissolved in solution which determine the direction and extent of the diffusion. Osmolality, the concentration of the solute per unit mass of the solution, milliosmoles per kg. Normal plasma osmolality is 285 to 290 milliosmoles per kg. What is osmolarity? Concentration of solutes per unit volume of the solvent, which is milliosmoles per liter. And we should know about the etiology of fluid deficit and type of electrolyte imbalance which will occur and which is associated with the illness and clinical status. And first we'll go about the introduction. The term crystalloid was coined by Thomas Graham in 19th century, which consists of water, electrolyte and occasionally glucose. The indication will be the replacement of free water and electrolytes and also in volume expansion. And principal component of the crystalloids will be the sodium chloride. And the predominant effect of crystalloid fluid is to expand the interstitial volume, not the plasma volume. Two basic types of isotonic crystalloid exist, saline and physiologically balanced solution. And which is the difference between colloids and crystalloids. Colloids, it include albumin, dextran and hydroxyl ethyl starches and gelatin. And it's a large molecule that stay in intravascular space longer and fast at expanding, and risks will be allergic reaction and coagulation problem. And the cost is more here. Crystalloids includes hypotonic and isotonic solution, small molecule that don't stay too long in intravascular space. High amount of fluids needs to be equal amount and no allergic reactions or coagulation problem. It is cost effective. And next is the sodium chloride in water dissociates to provide sodium and chloride ions. Sodium is the principal cation of the extracellular fluid and plays a large part in the therapy of fluid and electrolyte disturbances. Chloride has an integral role in buffering action when oxygen and carbon dioxide exchange occurs in the red blood cells. And next is a classification of IV fluids, which is based on maintenance, replacement and special fluids. Maintenance will be replaces the fluid loss from lungs, skin, urine and feces. And replacement based on losses in gastric drainage, vomiting, diarrhea, fistula drains and infection and in burns, which will be isotonic saline, DNS or oral. Specific fluids will be of hypoglycemia, hypokalemia, metabolic acidosis, which is 25% dextrose, injection sodium bicarbonate and potassium chloride. Next is the classification based on tonicity, which will be isotonic, hypotonic and hypertonic. Isotonic will be 0.9% NS and oral and 5% dextrose in water. And hypotonic will be 0.45% NaCl, 0.3% NaCl, 0.2% NaCl, 2.5% dextrose in water. Hypertonic will be 3% NaCl, 1.8% NaCl and 7.5% NaCl. And this is based on isotonic IV solution when the concentration of dissolved particle is similar to that of the plasma, and hypertonic IV solution have lower concentration and tonicity of solutes. Its osmolality is less than 250 milliosmoles per liter, and infusion of hypertonic crystalloid solution into the vascular system causes unequal solute concentration and fluid to shift from the intravascular space to both the intracellular and interstitial spaces. Next we will come to hypertonic solution, which is a higher tonicity or solute concentration, causing an unequal pressure gradient between inner and outer of the cell. Osmolarity will be 375 milliosmoles per liter, and osmotic pressure gradient draws water out of the intracellular space, increasing extracellular fluid volume, and hypertonic saline used as a volume expanders. And next first will come about the normal saline, which is 0.9% NaCl contain 9 gram per liter of NaCl with an osmolarity of 308 milliosmoles per liter, and osmolality will be 285 milliosmoles per liter. Composition will be sodium of 154 milliequivalents per liter and chloride is 154 milliequivalents per liter. And next is the pharmacological basis based on sodium chloride present in extracellular fluid. So isotonic saline is used to provide major extracellular electrolytes. It also increases intravascular fluid volume. Indication hypovolemic shock, vomiting, diarrhea, diabetic ketoacidosis, and treatment of hypercalcemia, dilution of various drugs, and irrigation of bladder and abdomen. Its contraindication is fluid overload status, careful administration in young and elderly patients, dehydration with severe hypokalemia, hypernatremia in hypochloremic acidosis, and conscious use to avoid in hypertension pre-eclamptic patients. and 0.45% saline. So sodium chloride injection is sterile and non-pyrogenic. It is a parenteral solution containing sodium chloride in water for injection, intended for intravenous administration. It contains each 100 ml of 0.45% sodium chloride injection contains 0.45 gram plus 5 gram of glucose. Electrolytes per 1000 ml. Sodium is 77 milliequivalents, chloride is 77 milliequivalents, osmolarity is 154 milliosmoles per liter, and hypotonic and pH is 5.6. An indication is ideal solution for fluid replacement since its tonicity allows movement of fluid to remain in intravascular space. It is used in pediatric patient, hypernatremic patient, DKA, gastric fluid loss from NG tube, suctioning, vomiting, and water replacement. Less value for replacement of NaCl. Next, contraindication of normal saline. When administered alone, it can deplete intravascular volume and cause cellular edema, and not used in head injury or raised ICP, trauma, burns, and severe dehydration. 3% NaCl saline. Composition is 30% NaCl, 30 gram per liter. Sodium is 513 milliequivalents per liter. Chloride is 513 milliequivalents per liter. It has a osmolality of 900 milliosmoles per liter, 3 times that of the plasma. It is available in 100 ml, and increased serum sodium and osmolality will decrease ICP. Indication in severe hyponatremia. Sodium is less than 115 milliequivalents per liter. Intracranial hypertension, hepatic encephalopathy, and cerebral salt wasting. 3 grams of NaCl per 100 ml, which gives off 51.3 milliequivalents per 100 ml. Calculation is desired sodium minus serum sodium into 0.6 into body weight in kg. And if no convulsion or patient is drowsy or stable, 30 to 50 ml per hour infusion, and check sodium every 6 hours. Sodium correction should not be more than 8 to 10 milliequivalents per liter per 24 hours. And adverse effects. Hypertonic saline cause skin abrasions. Monitor IV closely for patients. Receive 3% saline peripherally and use central lines for higher concentration. Hypertonic saline cause hypokalemia and hypochloremia and metabolic acidosis. And dextrose, its compensation is 1 liter of fluid contains 50 gram. Pharmacological basis, corrects dehydration and supplies energy. Best agent to correct intracellular dehydration. It is selected when need for water but not electrolytes. And its indication is prevent and treatment of dehydration. Cheapest fluid for pre and post operative fluid replacement for IV administration of various drugs. Treatment in prevention of ketosis, diarrhea, vomiting, high grade fever. Adequate glucose infusion protects liver against toxic substances. Correction of hypernatremia in diabetic insipidus. And it's contraindicated in cerebral edema due to hypotonic in nature. Neurological procedures, acute ischemic stroke, hypovolemic shock, hyponatremia with water intoxication, hypernatremia, blood transfusion, uncontrolled diabetic, and severe hyperglycemia. And precautions. IV administration cause local pain and vein irritation and thrombophlebitis. Prolonged IV administration cause hypokalemia, hypomagnesemia, hypophosphatemia. And we have next is 25% dextrose. Each 25 ml provides 6.25 gram of dextrose. Each gram of anhydrous dextrose provides 4 kilocal. And hypotonic solution, as it does not contain cation, and hypoosmolar solution 1389 milliosmoles per liter. Indication is hypoglycemia, used as a source of energy, particularly in total parenteral nutrition, treatment of hyperkalemia with insulin, and coma seizure. And the next is DNS. Each 100 ml contain glucose 5 gram and sodium chloride 0.90 gram. 1 liter of fluid contain glucose 50 gram, sodium is 154 milliequivalents, chloride is 154 milliequivalents. And pharmacological basis, fluid has advantage of providing both to provide energy and source. 0.9% of isotonic saline. It rapidly corrects the NaCl deficit of extracellular fluid. Next indication will be correction of salt depletion and hypovolemia with supply of energy. Correction of vomiting or nasogastric aspiration, and fluid compatible with blood transfusion. Contraindication anasarca and hypovolemic shock, and rapid infusion of DNS can cause hyperglycemia and osmotic diuresis even in presence of fluid deficit. Thank you.